Sir, can you hear me? Hello.
Chetan.
Yes, sir. My voice is audible.
Yes, yes, you are loud and clear.
Okay, sir.
Can you give me the attendee ID password?
Attendee link.
हाँ हाँ.
Sir, I'm just typing in chat box.
Yeah, yeah. Or should I give you my mobile number? Can you just WhatsApp me?
Okay, okay. I will just send you through WhatsApp.
Yeah, I'm typing my mobile number.
Okay, okay. Just type in chat box. Yes, sir. I received it. I'm just testing you on WhatsApp.
Yeah.
हेलो चिन्मय जी। हेलो।
Hello.
हाँ चिन्मय जी।
Yes, sir. Chetan from Net Support.
हाँ चेतन हो तो यस। चिन्मय जी भी है ना वो। अरे चिन्मय जी
हाँ,
हेलो।
हाँ ओंकार जी बोलिए.
हाँ अभी डॉक्टर अभी ब्रीफ करना पड़ेगा उनको मॉनिटर को।
हाँ हाँ.
कौन है मॉनिटर कौन है?
डॉक्टर सुनीप बनर्जी. सुनीप
सुनील
SUNIP.
बनर्जी। यस यस।
He is a top fellow here in Calcutta. मतलब top 5 कार्डियोलॉजिस्ट में से एक है.
ओके ओके।
वो थोड़ा हाई नोज है ओंकर जी.
अच्छा।
ठीक है. I'm trying to connect you over phone.
ओ और
Let's see.
फोन।
हाँ उसको एक बार रिमाइंडर देना पड़ता है.
अच्छा तो उनको फोन कर रहे हैं अभी आप करिए ठीक है।
हाँ 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 हाँ.
ठीक है।
Saurabh. Hello. Saurabh, you are audible?
Yes,
Saurabh,
yes.
am I audible?
Audible.
Our panelists are joining now.
Yes, yes. Everybody will be joining
Okay.
within next 5 minutes.
Okay. স্যার নমস্কার।
চিন্ময়বাবু কেমন আছেন?
এই তো স্যার, আপনি কেমন আছেন?
ভালো আছি। শোনা যাচ্ছে?
হ্যাঁ, লাউড অ্যান্ড ক্লিয়ার স্যার।
ঠিক আছে, তাহলে এসিটা চলছে আর পাখা চালানোর দরকার নেই। আচ্ছা, আমি
Right,
যেটা সেটা হচ্ছে যে আমরা মানে আমি যেটা বানিয়েছি জাস্ট
right.
হোয়াট ইজ ইউর প্ল্যান হাউ টু প্রসিড উইথ ফার্স্ট?
Sir, we have our coordinator from Mumbai, Mr. Onkar Mahakal. Onkar ji,
Sir, good evening.
Yes, good.
our moderator sir is there. Can you just brief the flow of the meeting to
Yeah,
sir?
sir, good evening. My name is
Yes.
Onkar Mahakal,
Yes,
Head Office, Mumbai.
yeah.
Sir, welcome to first of our debate webinar. So let me share you.
Why you are not showing your face? Show your face.
Yeah, just a minute, sir. Just a minute, sir. Yeah.
Because Onkarnath is one of my favorite players.
Okay, okay. Nice to
I
know, sir.
was in Bhopal for a
Nice
long
to
time.
know.
Yes.
Okay.
Go ahead, tell me.
So how are you, sir?
Just pulling on.
Right, sir, right, sir. So let me share my screen with you first. So I will show you the entire flow of the entire debate platform presentation.
Mhm.
So basically, there will be, sir, two case studies on the
Yeah.
debate webinar. So
I have
one
seen.
case study, yeah. So this is basically open discussion, wherein the one case will be presented by either you or me, whichever is convenient. So can you present the case, sir, or I should present the case?
I will present, not an issue.
Yeah, sure, sir. So after the case presentation, you can ask the respective panelist doctors to give their opinions on how to manage the case, either with clopidogrel or prasugrel or Takhilor. So one case will be discussed for around 15 minutes. So after
Yeah.
the first case, we will move to the second case, which is on dabigatran and atrial fibrillation.
Hmm.
Here also, you will present the case and ask the respective panelists to give their opinion how to manage the case with either NOAC or either VK and so on.
Okay.
And afterwards, we'll move to the question answers from the attendees and we'll close. So overall, 40-45 minutes we will take to complete the entire debate webinar.
So the first case is the acute coronary syndrome.
Yes, yes, yes. First
Okay.
case, correct, sir.
So show me the slides.
Yes.
Okay. Okay. Actually, okay, fine. How many slides are there? 9.
9 slides, sir. Yeah.
Okay, okay, this is good. No, this you what you do, you just I'll tell you to move the slides,
Okay,
and
I'll move.
that will be better, because just briefly show me the slides once more.
Yeah, just I'll make the full screen, sir.
Yeah,
You
please.
can view it better.
Next.
There is the ECG over here.
Next.
Then the treatment options are there, sir, to be
Next.
discussed upon. And then we move to the second case of AF.
Yeah. So after the first, I discuss this.
Yes,
Okay.
yes.
Just show this all.
Yeah. This is on AF, sir.
This I've seen. Next.
Clinical examination of the patient.
Okay, fine. Next.
And what points should be considered while managing the patient?
Great.
Here we can discuss. So basically, we made concise the PPT. So in short time, we can cover or discuss major points.
No, major thing. So I have also made the things like this
Okay.
to tell you, Omkar.
Yes, sir.
In the first case, I will say that I will behave myself as a general practitioner.
Okay.
So I will tell them that I will treat this patient conservatively if the TROP-T is negative and the pain subsides with nitrate. Then I will tell that I will refer the patients to the hospital, which is 3 hours from here. I will not take any risk because it is a heart attack case. Okay.
Okay.
And they will criticize me. That is the thing I wanted.
Okay.
And then I will tell them that I wanted to thrombolize him, and with thrombolysis only I can give clopidogrel. So that is also wrong because you have a evidence that ticagrelor can be given safely with thrombolysis. Okay.
Yes.
Similarly, in the second case, I, as a practitioner, I'll talk on this point. What I have decided that I am not going to investigate this lady further. I think it is an anxiety problem. Then I will ask, okay, if you wanted to check AF, what are the detection tools, and then why you wanted to give blood thinner, because that is risky for the patients. And then, as you said, and then last one I have made, if you have given dabigatran, then what are the ways you are going to follow it?
Okay.
I think that makes it sensible.
Yeah, that's a great way to approach the case.
Yeah,
can give the comments.
Because like if I behave like this, then I wanted to behave like the audience. So
Yeah, not a
you
problem.
have a direct audience in this, or you'll be
Separate
showing
link
it
we
up?
have. Separate link we have separate audience.
Thank you.
Yeah.
So that's fine. Then you start the thing, and then you introduce all the speaker. And for me, just give a brief introduction, not big. Dr. Banerjee is there, not he's associated with here, nothing, please. And then you give the first case, and then I will show you how to move it. Okay.
Yeah. So my presentation will be on the screen, sir. Then.
Yeah, you will be
Control of the presentation.
Rolling the
Slides.
because control will be with you.
Yeah. So basically,
I'm not
Chinmay sir
going
will
to-
introduce. Sir.
Yeah, I'm not going to share anything.
Okay. Okay.
Okay.
Not a problem. Fine, sir.
And if there are certain things which is like if in this gray zone where you have to look for multiple other factor to look for am I not audible?
Audible, sir.
Okay, so like there is a slide on my part where just not the ECG detection of AF, but the other thing which has come from the 2020 AF guidelines. So if I wanted to show them a little bit, will give, I mean, AF detection, anticoagulation beyond ECG.
Okay.
So, so that if I think I just present 1 or 2 slides.
Sure, sir. Sure.
At that time, you just need to share it.
Yeah, not a problem, sir.
Thank you.
Sir, Dr. Shomokanti Dotto sir and Dr. Tanmoy Majhi sir has joined already.
Very good.
Shobhik Kanjilal sir has already also logged in.
So, who is left?
We're just waiting for Dr.
Tanmay or
Dr. Shudev sir. Shudev sir, we are waiting.
Shudev Mukherjee, sir.
Let me talk with Shudev sir. Saurabh, if you can try Shudev sir once.
Yes.
8:56. So we have 5 minutes. I am just getting myself connected.
Right.
Not changing.
Yes, sir. Yes, sir. Sir, very
Chinmay,
good evening to all of you, sir.
Yeah, Chinmay, you are based nowadays in Mumbai only.
No. I am in Calcutta, sir, looking after entire East Zone as a zonal manager.
Oh, yeah. Right.
Tanmay Shah is visible, sir. His video is on. Sir, good evening. Namaskar.
Good evening, sir.
Good evening, Tanmay.
Good evening, sir. So actually, I'm trying to connect it in the laptop. Laptop e connect korte jacchi mobile e
Sir, there is a mail from.
Not comfortable in mobile, but anyway, but your connection seems to be very good.
Tanmay sir, the problem is if you get a phone call, then you'll get disconnected, sir.
Yeah, that is the problem actually with phone. Okay, anyhow, actually, I have
So
not got the
direct
link.
from the mail you can log in, sir.
No, mail se পাইনি. I have not received the mail from you yet.
এই
Okay.
এখনই পাঠিয়ে দাও তাহলে।
Ha, Saurav. Or sir, I'm sending you the mail once again.
Hmm.
Sumit, you can log out and connect with Sudhe Mukherjee, sir.
Sudev Mukherjee sir is joining. I'm just
Okay. Saurav,
next 3 minutes.
Tanmay Maji, sir, is yet to get your mail. Can you forward it once again?
Okay, I'm forwarding. One second.
Kanjilal sir, namaskar. Good evening.
Good evening. Good evening. Good evening, everybody.
Good evening.
Good evening, sir.
Good evening, sir.
Sir, we are just waiting for Sudev sir. He is about to join in a couple of moments. Tanmay sir, I have sent you the link.
Okay. Okay, I've got it.
Tanmay sir, I have sent you once again the link through mail. Can you just have a check at it?
Saurav, we are about to start. Just waiting for Sudev sir to join.
Omkar, how is the situation in Mumbai?
It is
Improving.
slightly improving, sir, since couple of days.
Hmm.
Yeah, but just people should continue to follow this measures of lockdown and stay at home, not
Yeah.
and carry all the preventive measures. Then only
Right.
things can come
But
under control.
what is your feeling on the lockdown extent, which was there 1 year back, which was very extensive one? Is that strictly being followed now also?
Yeah, it is being followed, sir, in many of the city parts of the city. Even but in marketplaces, if you go like towards the slum areas, there it is difficult to follow situation. Otherwise, in cities, it is being followed very judiciously.
Fine.
Likewise.
So has Dr. Sudhir joining? Tanmay has joined. Probably Tanmay got the link from the mob.
Right, sir. Hello. Okay. Sir, Shudev sir is on his way. So if you permit, we can start.
Yeah, before we start, I just have a small announcement for Dr. Maji, Dr. Kanjilal, and Dr. Datta. All are audible?
Yeah, of course.
Fine. So
Yeah.
I think we have seen these two cases. So my idea is that I will be presenting this slide, and then my approach will be like a general practitioner. So you people are going to correct it. Like in the first case, I say that I don't want to thrombolyze if the topic is negative. I want to give nitrate, and then I'll say that I refer the case. I don't do anything. And the third thing is that if I thrombolize, I'll give only clopidogrel, because ticagrelor can produce harm. So these are the things I am going to say. So, and in the next case also like that. So I think that is all. Dr. Maji, Mr. Dr. Datta, you agree on that?
Yes, sir. Yes, sir.
Yeah. So and then I will take your opinion, and then you people will be focusing on the facts and try that everybody speaks on their ways which is not been covered up by the others. That is the best way to go ahead. Fine. So with the green signal, Chinmay, we can start.
Yes. Good evening, all. On behalf of Alchem Lab, India's 5th largest pharma company, I welcome our respected moderator, sir, and all eminent panelists and all the doctors who have joined us for today's anti-thrombotic debate. As you know, at Alchem, it has always been our endeavor to partner with healthcare professionals and the medical fraternities. And in this difficult time also, we continue to do so. To help us to navigate this session, today we are extremely fortunate to have renowned interventional cardiologist, Dr. Sunip Banerjee with us. As you all know, Dr. Sunip Banerjee has I don't have to give any introduction of Dr. Sunip Banerjee. He is a renowned interventional cardiologist, and he is a DM cardiology from PGI Chandigarh. He has been a faculty of PGI Chandigarh as well. And sir has been clinical director of Medica Super Speciality Hospital. Sir has served as a chief of cardiology in Fortis Hospital as well. And sir has been a director in RNT, Rabindranath Tagore Institute of Cardiac Sciences as well. I take this opportunity to welcome Dr. Souvik Kanjilal sir as well. Sir is an interventional cardiologist of Ramakrishna Mission Seva Pratishthan, Ruby General Hospital, and Aurobindo Seva Kendra. Sir has been involved in as a speaker, panelist, and chairperson in all the national conferences over the last 10 years. Welcome, Dr. Souvik Kanjilal, sir. I take this opportunity to welcome Dr. Tanmay Maji, sir, as well. Sir is a senior interventional cardiologist from SSKM, and sir is currently attached with Ruby General Hospital. Tanmay, sir, most welcome. I take this opportunity to welcome Dr. Shaumakanti Datta, sir, as well. Sir is an interventional cardiologist and gold medalist from SSKM. and sir is currently working as a post DM senior resident in SSKM. Welcome, Dr. Somakanti Datta, sir. And I take this opportunity to welcome Dr. Shudev Mukherjee, sir, as well. Sir is a senior interventional cardiologist attached with AMRI Hospital. With this small brief introduction, may I request Dr. Shunib Banerjee, sir, if you can start the debate.
Yeah, great. So, good evening, everybody. Saturday evening, we wanted to make it a good discussion, and I am happy from Alchem's people that they have invited me to moderate the session, and my ideas and focus will be to concentrate on two cases which are very practical, and I will be presenting this case, and I will be trying to focus on very basic thing. And my eminent panelists, who are very learned and not only learned, they are actually more aggressive, more young, dynamic bloods. So they will be able to give the rationale of management for this case. So with this, I will request Mr. Onkar, can you please show the slideshow of the first case, and I am going to read out the case and ask questions on the points, please. So this is a 72-year gentleman who has come very importantly in the emergency department complaining of sudden onset chest pain for last 1 hour. Now, pain is typical of cardiac origin, as the emergency doctor has assessed. He's a smoker, he's not diabetic, and he had a history of hypertension. And the ECG shows extensive inferior wall myocardial infarction. And the biomarker is positive, blood pressure and heart rate is very stable. So, okay, now I don't behave myself as a cardiologist. I will behave myself rather as a general physician or a patient population. If this patient is 72 years old, who has definitely a retired person or may not have insurance. So even it is, if the biomarker is negative, and if the ECG, can you see the ECG? Next, please. Okay, the ECG shows ST elevation. So my point is that if it is ST elevation MI also, I wanted to give with nitrate and antiplatelet and heparin and wait for sometimes if the pain settles down, then I am not going to do anything. This is my opinion, and but I know I may be wrong, and I wanted a clarification from my colleagues. Next slide, please. And I have a reservation for giving ticagrelor or even prasugrel because these are all strong drugs, and this person is 72-year-old. So I just wanted to give even clopidogrel 300 milligram, not 600 milligram. And if the pain subsides with nitrate, and if the TROP-T was negative, I wanted to keep him at home or in the emergency, even why I should do anything more, and I should do a repeat ECG after giving a nitrate. So this is my opinion. And my first question goes to Dr. Kanjilal, that do you agree with my approach?
Absolutely not, sir. I beg your pardon. I'm sorry to differ from you. Actually, this patient is having inferior posterior wall mitral infarction, and that means the patient is at high risk of developing significant complications, number one. Number two, since the patient is arrived in the golden hour, that means within 3 hours of index event, the patient should get the benefit of reperfusion in the form of either PCI or at least a thrombolysis if PCI facility is not available or if the primary procedure cannot be performed. And regarding loading of dual antiplatelet, of course, clopidogrel can be given, but there is no harm. Rather, it's always beneficial to have a better drug than clopidogrel, which in this case seems to be ticagrelor, because we don't know the anatomy of the lesion. We haven't done the angiography yet. So loading can be done with ticagrelor as well. In fact, in my opinion, ticagrelor will be better drug compared to clopidogrel, and this is how we go about it.
Thanks for your short, beautiful comment. I next go to Dr. Maji. Dr. Maji, I think if you wanted to give ticagrelor, this is a costly drug. And the next thing is that if I give clopidogrel, I know it takes some time to peak into the blood level. What is the problem? I can give clopidogrel. It's a very less costly drug and probably produces less bleeding, as I know. So I can give clopidogrel. It may act after 1.5 hours. But what is the problem? Why ticagrelor?
So first of all, if we are planning for PCI, urgent PCI, primary PCI, we need platelet inhibition within the next 90 minutes to 120 minutes. So in that case, ticagrelor is the best because the half-life is short and satisfactory platelet inhibition occurs within about 90 minutes. Whereas as far as clopidogrel is concerned, platelet inhibition takes about more than 4 to 6 hours to achieve proper platelet inhibition. And though clopidogrel can give even clopidogrel being a prodrug, and in the it needs conversion to active drug in liver to achieve the active active metabolites. So in that case, if we consider either primary PCI, in that case, I think ticagrelor will be better in front. But if we consider thrombolysis, in that case, we should use clopidogrel, I think.
Okay, great. So all my impression is get nullified. So let's see what Dr. Shomo says. Shomo, you are available?
Yes, sir. Yes, sir.
Yeah.
I do agree with Dr. Tanmoy Maji and as well as Dr. Souvik Kanjilal that if the thrombolysis facility is there only and no facilities for primary PCI, then only I will go for clopidogrel loading dose, because with thrombolysis still we don't have any sufficient data of ticagrelor loading associated with thrombolysis with either streptokinase or tenecteplase. And if the facility of primary PCI is available, then considering is a inferopostural MI, I will definitely load the patient with 2 tablets of ticagrelor as well the aspirin and the statin definitely with higher doses. Then I will take the patient to the cath lab for primary PCI. And considering postural MI and possibility of RV infarction as well, I will not allow the patient to have nitrates, obviously.
Oh, that's also a great point. And because nitrate can produce hypotension.
Hypotension, yes.
And it can further jeopardize the symptomatology. So this patient has all the risk factor for coronary artery disease and has presented with a typical chest pain. And he is the person who is going to be most benefited with a thrombolysis or angioplasty procedure. Now, the next important problem comes to Dr. Sudeb. Sudeb, you are available? Dr. Mukherjee?
Sudeb sir has logged in, sir.
Okay. Just I wait for a while.
Hello.
Chetan, if you can, Sudeb sir, am I audible to you?
Yes. I'm sorry for being late.
Not an issue, not an issue. We wanted to see your face. That's most important. Yeah.
Sure.
Great. Sudeb, you may be aware of the problem that we have a 70-year-old male who has presented, who has a history of MI, smoking and hypertension, and his ECG shows extensive ST elevation MI in the infraposterior lead. So I, as a practitioner, thought that he can be managed conservatively with nitrate if the TROP-T is negative, but that has been nullified by Dr. Kanjilal. And I also thought that he may not be giving any large amount of antiplatelet drug, but that has been also nullified by Dr. Tanmoy Maji and Shomo Dutta. So all of them feels that these patients should be receiving high dose of antiplatelet at the beginning. And my question to you is that at a 70 years old male, ticagrelor is safe to give. A. B is I don't want the patient to be treated by me, because if something goes wrong, I will be in soup. So I want to shift him to a hospital where cath lab is there after, and it will take 3 hours. And although I have in my hand streptokinase or reteplase everything, but I don't want to give, because if something goes wrong, he is known to some of our political leaders, so I don't want to do anything. So how you are going to tackle it? Your point is very difficult now. First of all, do you want to give any treatment if the definitive treatment is 3 hours late? Number one. Number two is, do you think ticagrelor will be safe in this patient?
Sir, first of all, this 70 years gentleman, as you are saying, suffering from acute inflammation.
Yes.
Yes. So, considering the STEMI with the 3 hours duration, definitely the PCI is the first choice. And during the PCI, we should give high dose antiplatelet. There is no denying of the facts. And in that scenario, ticagrelor definitely, along with aspirin, is the option. And the 70 years is not a contraindication to give any kind of high antiplatelet during the procedure, during the PCI. So along with all the management that the patient should be receiving, he or she should get a high dose antiplatelet, the aspirin loading along with ticagrelor during the procedure. That's my opinion, sir. And if the patient was PROP-T negative, then we should have managed with conservative way, assessing the risk. But if the patient is PROP-T positive, along with definitely ECG evidence of acute MI with 3 hours duration, then PCI is the first choice. If it is not possible to get the patient in a PCI capable center, then we can manage it conservatively. In that scenario, if thrombolysis is available, then we should go ahead with thrombolysis. We do have options with reteplase, tenecteplase, and if still thrombolysis is not possible, if the patient is getting admitted in any peripheral center where the treating physician is not so much well equipped with this kind of treatment, and if it is not possible during this pandemic situation to transfer the patient to any nearby well-equipped healthcare facility, then we should be treating with definitely also with high dose therapy. And in that scenario, along with aspirin, ticagrelor is definitely a good option.
Fine. Dr. Sudhir, please, still as a physician, I think I should give thrombolysis rather than waiting for 3 hours to shift him. And a pharmaco-invasive approach may be better, provided the risk of bleeding is not very high. And the other thing is that if the patient agrees for a small risk of intracerebral bleed of thrombolysis, this is my opinion. And the other thing so now from the first part of the discussion, it is very clear that you all feel that this is a acute MI and this has to be managed immediately. Yes. And with the immediate management, it is the strong antiplatelet which is important, and ticagrelor you have opted out because it is the direct acting, it bypasses the liver, and it has a safety profile which has been well documented. Now, yes. My question to Dr. Kanjila Leger. I have given ticagrelor, and fortunately, I have been able to do a angioplasty. And next morning, I found that the patient is having a sinus pause. So, and the heart rate is intermittently coming around 40 or 50. So what I am going to do? Should I stop ticagrelor or we wait? Otherwise, the patient has doing very fine and he doesn't have any problem. But the ECG in the monitor is showing intermittent sinus bradycardia, not very much, up to 40-50. This much. There is no AV block, no PRE prolongation, just a sinus bradycardia. And he says that I am feeling a little bit out of breath. So these are the two side effects we know about the ticagrelor. So what do you feel about it, sir?
So I would never like to stop ticagrelor in this case because fortunately all the side effects that we face with ticagrelor because of the increased adenosine availability, be it dyspnea, be it sinus sinus pause. Fortunately, they're all very transient in nature, and usually they go off on its own, or sometimes we may require verifying or things like that. So it's never a prudent decision to stop ticagrelor in this case because ticagrelor is the most potent, and rather is more potent than clopidogrel. And once we have started ticagrelor, there is no question of stopping this because of this simple side effect.
Thank you. So, Dr. Tanmay, this patient with ticagrelor during discharge, day of discharge, has developed some bilateral wheeze and saying, I am getting intermittent cough. And you did a bedside echo and you found a good LV function and there is no valvular regurgitation. And that's all. And then do you think that this dyspnea can be due to heart failure or because of the ticagrelor?
Sir, kindly unmute yourself, Tanmay sir.
Yes. Dyspnea with ticagrelor sir is well documented, but as Dr. Kanjilal has said, this dyspnea or pause, these are temporary side effects. Maybe due to some, of course, we should think of other causes. We should think of heart failure. We should do an ECG. We should assess the IVC before discharging if the patient develops these complaints. And right now, in this corona situation, we should also consider some recent chest infection or something like that. But if it's only due to ticagrelor, I think other parameters are normal. A chest X-ray or echo or some NT-proBNP or IVC are normal. This dyspnea usually subsides by itself. Even PFT is found to be normal with ticagrelor if you do a PFT. So not much of concern with that if other parameters are normal.
Fine. So that's a great answer. And I think these two side effects, breathing difficulty or auscultatory wheeze, all these things usually passes off over a period of time. This is very important. And even a feeling of chest tightness, because this patient who has suffered AMI always concerned about it. But we can assure them that this is only going to be short-lasted and not going to be prolonged for a long time. So next, Shomo, I have one question to you on this ticagrelor related issue again. That do you think that this patient is too much of a gastric irritation? You can stop the aspirin and send this patient home only on ticagrelor? How comfortable you are in doing so?
After angioplasty, sir. After doing primary angioplasty.
You have done angioplasty, patient is going home, but in
I shall be scared to send the patient in only with ticagrelor. If there is definite history of any GI bleed, then obviously I shall think twice. But if the patient is asymptomatic after angioplasty, and obviously apart from those side effects as you have discussed, sinus pause or bradycardia or dyspnea, if the patient is complaining of any other thing, I shall definitely send him on DAPT. Obviously, I will not stop aspirin, neither aspirin nor ticagrelor for at least 3 months.
Great. And you wanted to give, suppose this patient's body weight is 90 kgs, you wanted to give 25 milligram aspirin or 150 milligram?
So I obviously prefer 75 milligram because there is an American paradox that we should not increase the aspirin dose of more than 100 milligram with ticagrelor. It increases the bleeding risk. So if I am prescribing ticagrelor, obviously the aspirin dose should be either 81 milligram, which is not available. So in Indian market, obviously 75 milligram is preferred dosage.
So excellent, Dr. Shomo. I think we need to understand, whoever is attending these sessions, that all our cardiologists, they are all well read despite their busy schedule. And these small things matters actually in the long term. Now, the next question comes to Dr. Sudev, and this will be the last important question for these patients, is that do you think that if I have thrombolized this patient and still it is a failed thrombolysis, and I am shifting these patients to a center for PTCA, and suppose I have given a ticagrelor, have I done any harm? Suppose I think I thought that, okay, ticagrelor acts fast. I wanted to give it right now. Don't wanted to give clopidogrel, but if it is clopidogrel resistance or it takes some time, so I have given, and then suddenly patient's relative decides that they are not going to do any angioplasty. They wanted to take him away, and or they wanted to give thrombolysis. Two possibilities: no PTCA, only thrombolysis, or medical management. Do you criticize yourself of giving clopidogrel, ticagrelor in a ST elevation MI? Yes or not? If it is yes, clarify.
Shudev sir, kindly unmute yourself, Shudev sir.
Sorry. Yes, actually we can do, sir. The question is regarding if we do not plan for PCI also, whether we can give it for ticagrelor, I can do thrombolysis. Yes, we do have a data regarding the fact that that ticagrelor can be given in that scenario where thrombolysis is planned, and even after a failed thrombolysis, you can go ahead with ticagrelor also. So there is no denying of the facts that we have a safety data regarding ticagrelor in that scenario post thrombolysis.
Great. So all of you feel that in this patient, ticagrelor should be given, whether he is being managed medically or by angioplasty or by even thrombolysis. I just was going through a trial which came in American Heart Journal in 2018 on the trial's name is STREET, which shows that if you have given thrombolysis, even with the latest generation thrombolysis with ticagrelor, the chances of bleeding is not more than clopidogrel. So probably that in this first case, who has a ST elevation MI, as a moderator, I might take home message will be that this is the drug which can be safely given. There is a study which is called CRUSH study, which ultimately not shown will be beneficial, that is crushing the tablet and giving it, or even pre-hospital ticagrelor has not been found to be good. But if you see the pharmacokinetics of this drug reaches its antiplatelet activity very quickly within 1 hour. And that's the beauty, because it is the platelet and platelet which is the culprit. And they invite the other culprit people like fibrinogen and red blood cell. And that's how the whole infarct goes on. So probably ticagrelor definitely in acute coronary syndrome is the drug of choice. And acute coronary syndrome is a disease of prediction, clinical judgment. And if you have a clear-cut changes, ST elevation or ST depression, there is no harm in giving ticagrelor. Your procedure, whether you are going to manage invasively or by medical management, all goes by risk stratification. And those who are practicing medicine, not cardiology like us, please feel to discuss with your cardiology friends or whom you refer very clearly about these cases, because time is important. Earlier we used to say time is muscle, but it is not only the time. It is the time to platelet inhibition is more important than anything else. And a very short comment from Shouvik, Tanmoy, Shudev and Shomo on this case.
Thank you for summarizing everything, but I want to chip in with one more point, that ticagrelor has got some pleiotropic effect as well, apart from antiplatelet activity. Ticagrelor reduces the inflammatory state. It reduces the pro-inflammatory secretions from the platelet, thereby reducing the inflammation. And it is very important, as we all know, that acute coronary syndrome is actually a systemic inflammatory state. And reducing inflammation will stabilize the plaque, which help in reducing the clot burden. And in that way, ticagrelor has got immense effect. And also ticagrelor increases the, it rather increases vasodilatation because of the action of adenosine on A2A and A2B receptors. So ticagrelor has got antiplatelet activity as well as pleiotropic activity, and that makes this drug unique among all the other P2Y12 receptor antagonists. Thank you.
Dr. Tanmay, please.
As far as acute coronary syndrome is concerned, it's an acute emergency, and we need some antiplatelet molecule which are truly efficacious, which have very rapid onset of action, and quite safety as far as bleeding and other parameters are concerned. And ticagrelor scores over others PY2 inhibitors such as clopidogrel and prasugrel in this respect. So I think in ACS presentation, ticagrelor is one of the good molecules as antiplatelet.
Great. So all are opine. Sudhir or Shomo, please, short impression.
Sir, I think ticagrelor is definitely one of the choice along with aspirin whenever you are considering PCI or any conservative medical management, even in cases of thrombolysis, as we have just said in TREAT trial, the late administration of the thrombolysis has not shown the increased bleeding. So ticagrelor definitely should be the choice.
Right. And Dr. Dotto, you think?
Yes, sir. Yes, I think everything is discussed about ticagrelor, but I have a question to you all, sir. Suppose a patient is thrombolized loaded with 300 milligram of clopidogrel, and the thrombolysis gone unsuccessful. That means the failed thrombolysis, and again I have to take the patient to the cath lab for a pharmacoinvasive therapy. Suppose it is a failed thrombolysis, then whether I should load the patient immediately within the 3 hours of loading of clopidogrel 300 milligram with 2 tablets of ticagrelor, or I should add 300 milligram of clopidogrel as the patient has already received streptokinase, full dosage of streptokinase.
Fine. So first I take the volunteer. Shomo, these are the questions which I dislike because these are the questions which is difficult to answer. No guideline.
Pardon me, sir. But these are...
You have put me in trouble. So I think here what happens that I do the procedure first, and then reassess that if it belonging to HBR, that is high bleeding risk category. If it is on high bleeding risk category, and high bleeding risk category is very dicey, hemoglobin less than 11. Most of our patients are less than 11. But is there any active bleeding? If the body weight is adequate, past history of bleeding, renal dysfunction, all these things, and the stent volume, stent length, what I have given. So these are my priority to decide on continuation of clopidogrel or ticagrelor. So probably after the procedure, I am trying to take a call on these things. Yeah, you three also please say something on this. This is a very important question.
Yeah, of course. I said the patient had 300 milligram of clopidogrel. So if we want to take the patient to the cath lab, then we have a few options. One, we can load with 300 milligram more. That is one option. And number two, if we want to switch to ticagrelor, if you consider that the patient is having high thrombotic risk and low bleeding risk, and if you want to shift to ticagrelor, this can be done within 24 hours itself. The beauty of switch trial is that in acute setting, when you want to switch from one P2Y12 receptor to another, there should be at least 24 hours gap. But in case of clopidogrel, when you're switching from clopidogrel to any other drug, there is no such time frame. So you can switch from clopidogrel to ticagrelor at any time you like. So there is no problem in switching. So I think in this case, we should stick to clopidogrel because we have already loaded with clopidogrel and the patient is having age of 72 years. What we can do, we can load with 300 milligram more and proceed the case. And if required, later on, we can switch to ticagrelor at any time.
Yeah, not before the procedure, because the patient is already has received not only the clopidogrel but the thrombolysis also.
Thrombolysis, right. Right.
You can very well see it after the procedure before.
So at the end, although I was debating on the issues of giving clopidogrel and doing a conservative management, but the 2021 scenario, And you have seen all these cardiologists is definitely in one tone has said that early intervention is the key to long-term decrease in heart failure. All of them has emphasized on ticagrelor loading dose. The third thing, which is maybe a conflict of interest, so I am taking the charge on that, is that think of the cost of the drug, and if the other molecule, which is less costly, and because this patient has to be on ticagrelor at least for a year. Beyond that, that's a different thing. So try to be sensitive about the cost and try to give the available ticagrelor, which one of them is Ticavic from our sponsor talk. So with this, can I request Onkar to go to the second case, please? So this is again a dicey situation. A 55-year-old male presented in the OPD with history of palpitation 2 days back, and it just was for 15 minutes. And she has just some hypertension, but she's not on regular management of telmisartan. She takes telmisartan intermittently, and there is no other history of cardiovascular disease, no history of diabetes. She belongs to upper middle class, the vegetarian dietary habit. So what it means to me is that probably this lady is sedentary, and I don't know whether she's obese or not. And obesity is such a sensitive thing to a 55-year-old lady. You cannot discuss also openly. She is not on any antiplatelet or any anticoagulant. Blood counter normal, thyroid function normal, ECG is normal, 2D echo normal, ejection fraction 55%. There is no chamber enlargement, no pericardial effusion, no RWMA. Next slide, please. And clinical examination is showing actually a good blood pressure at the present moment, but you don't know the 24 hours BP monitoring may be different. And she has been advised a 24 hours Holter monitoring, which shows a very short episode for 10 minutes. Now, with this thing in mind, my again approach will be, I'll just give her some anxiolytic and correct anemia, if any, and don't do any investigation. And even I will not tell that lady to take antihypertensive drug as the blood pressure is normal. So, Dr. Kanjilal, do you agree with me or not?
I'm not sure about the hypertension part, and with telmisartan 40, 122 by 84, I think we should stick with the antihypertensive. But regarding anticoagulation, no, I would not like to start on anticoagulation because of two facts. First of all, this atrial fibrillation, maybe it's a subclinical atrial fibrillation or SCAF that we call, because the palpitation may not be related with the atrial fibrillation at all. And number two is that the duration of atrial fibrillation is only 10 minutes. And such short run doesn't require any anticoagulation. So I won't like to put on any anticoagulation at present. And we'll try to stick with telmisartan only.
Dr. Tanmay, what do you think we should give a advice to this lady who is apparently not very sick? And you must have seen the problem that she doesn't want to take any medicine, but she's sedentary. And I tell you the fact that she is obese and she has a problem in the hip. So she is not, most of the time she is taking her rest at Puja Ghar, and she takes a lot of fried food, and she also snores. So do you think this has any implication on her AF, and you wanted to educate her further?
Yes, as Dr. Kanjilal says that he has presented the first time history of palpitation. His Holter monitoring showed a short run of AF that is also approximately less than 10 minutes. And she's having other comorbidities, obesity, and then sedentary lifestyle. I should educate her about lifestyle modification, and I should search other secondary causes, thyroid evaluations, and maybe serum electrolytes or other. I should go for the baseline investigations along with thyroid, and maybe after lifestyle modifications, I will want to see the patients at a later date also, maybe some couple of months, whether she is having the symptoms or not. And maybe, as you have suggested, maybe with a little anxiolytic and along with beta blockers can also be considered, low dose of beta blocker.
Right. So Dr. Shobik and Dr. Tanmay both emphasized on one thing, is that lifestyle modification and continuation of antihypertensive therapy, if it is controlled, and she has to be educated very clearly that your blood pressure is controlled because you are taking blood pressure medicine. Now the twist came, which is not there in this presentation, that this patient's son has brought a Apple Watch for her, and which detected intermittent atrial fibrillation for 6 hours or something. And this is not at the age of 55 years. Now she is 62 years age. So, but she is doing well actually with a regular physical activity. There has been a person who has been appointed specially to do a physiotherapy to relieve the hip pain. And she has been cut down on the diet, and she has lost 10 kgs of weight. She used to snore a lot at night, and she has decreased it, but the Apple Watch is detecting atrial fibrillation very frequently, and she gets a little bit of palpitation, but she is not willing to go to Dr. Tanmay Majhi or Dr. Kanjilal because her blood pressure is normal, and they are happy with their opinion. But with this Apple Watch reading, Shudev, the patient has come to you. What we are going to do?
Sir, first of all, I would like to say that although the patient was hypertensive, BP was within a control target level, but still patient was on antihypertensive. So if we calculate based on 10 minutes, less than 10 minutes of AF, first of all, it is not subclinical AF. Subclinical AF, what we call is that is not detected on ECG. On Holter, that is we called AHRE or subclinical AF. But whenever it is manifested in surface ECG, be it in Holter or in tubular ECG, then it's a clinical AF. Asymptomatic, although, but whether to need anticoagulation or not, that was your question in the first time. Then definitely my seniors have already stated it clearly: lifestyle modifications, and with a Chatsworth score of 1 at that time with the 55 age, only 1 with the female sex. Definitely, we don't want to put on a certain risk of bleeding. But after some time, there's the Apple Watch has shown that the frequent atrial fibrillation, then definitely.
Sorry, I am interrupting you. She is now 65-year-old.
Okay,
so it's
then 65 is
the yeah,
65.
that's why,
then,
yeah.
Then 65 with the age, the Chatsworth score is coming to 2. So we definitely need to put her on anticoagulation. Whether the obesity has decreased, the snoring has decreased, it does not matter, because if you calculate the Chatsworth score, then definitely it is counting to 2. So we need to put her on anticoagulation to prevent the increased risk of stroke. So that's a very clear-cut thing, sir. After this scenario, so along with life.
Right. And also I tell you one thing. I have done an echocardiogram, and which shows a borderline LA enlargement 41, and there are some left ventricular hypertrophy. There is some left ventricular hypertrophy, and I asked for all the investigation, and the cholesterol is high, and she has been found to have HbA1c 7.2. So with this thing, Shomukanti, you wanted to add more what Dr. Shudev has received the information?
Shudev has already, sir, actually added whatever the anticoagulation needed, because the Chatsworth score is coming 2 or more than 2 for that female. And the LA is borderline enlarged, so definitely the indication of anticoagulation and specifically the NOACs is definitely there. But as the HbA1c is rising with a female of 7.2, I shall definitely put her on either metformin, as the patient was obese And the newer therapies like SGLT2 inhibitors, definitely I would like to add for these patients. And it will have a benefit in those patients who had a little bit problem with atrial fibrillation, and the LA enlargement will have some relief also with decreased fibrosis in the LA. There is some evidence that SGLT2 inhibitors, it reduces to some extent also the volume overloaders.
Right.
So yeah, so I would like to add her on either or, as both the guidelines are there. But in my preference, I would like to add SGLT2 inhibitors definitely over and above and once.
Yeah. So when Dr. Shudev was saying the Chatsworth score was 2, when you were saying it is Chatsworth score of 3 almost. So coming back to Dr. Shobik, the problem what has come now is that she says that why I should take a blood thinner because Dr. Shomo has prescribed me a costly drug, and my husband used to take aspirin because he had a myocardial infarction, and that's very cheap. I wanted to continue on aspirin. So Shobik, what do you feel about it?
Well, it's my duty to make her understand that the chance of bleeding and chance of thrombosis, the balance between these two should be made properly. I mean, a patient of here, the patient's Chatsworth score is almost 3 because the patient is having a 6 category of female, hypertension, age is 65. And if you add LA enlargement, that means there may be a hint of HFpEF here. So maybe the Chatsworth score is more than 3. So here, the thrombotic risk is more than 2%, rather it's more than 2.4%. And the risk of bleeding with anticoagulation, especially with NOACs, is almost less than 1%. So if you try to balance between these two, her morbidity, her mortality will be definitely benefited with oral anticoagulants, and we should provide her with this benefit. And it's always our duty to make her understand.
Right. Dr. Tanmay, you now had the most difficult portions in this patient. So I have added aspirin, and somebody from US who has supplied the Apple Watch says, no, aspirin is not the good thing. So you need to give some anticoagulation, and he has prescribed dabigatran, and which is very costly, and he has given 75 milligram twice daily. So what you are going to do? Her age is 65 at the present moment. Her body weight is 72. Tanmay, you have to unmute yourself.
So as far thrombosis is concerned, oral anticoagulants are better than aspirin, and her Chatsworth score, as we have discussed, it's 3 or more than 3, and a thrombotic risk is more than bleeding risk. So anticoagulants, it will always be better. And regarding anticoagulants, we have the earlier anticoagulants, vitamin K oral antagonists, warfarin or acetrom, and on the other hand, you have newer oral anticoagulants, which dabigatran, rivaroxaban, or efixaban. But as you have already told, that this molecule may be costly, but if we direct head-to-head trial, we have shown that dabigatran with warfarin have shown but for better protection from CV or stroke than warfarin, and it doesn't require any monitoring as far the patient is concerned. So my choice will be to educate her, to told her about this molecule, I think that dose is in the lower range. Maybe it should be 110 milligram twice daily, because 75 milligram dose has not been in the RELY trial. We have seen that we have the 2 doses, the 110 milligram and 150 milligram. Though 150 milligram was superior, but bleeding risk was more. In this patient, I think 110 milligram twice daily would be the ideal dose.
Great. Am I audible?
Yes, sir.
Yes.
Yes, sir. Yes, sir.
Fine, fine. So we must remember Dr. Tanmay has emphasized first time on this issues is the Hasbury score. So we need to understand her hemoglobin, creatinine level also, and look after the Hasbury score and the Chatsworth score, which can vary in lifetime over a period of time. Also, Dr. Maji has mentioned about an important trial, that is the RELY trial, which is the first breaking trial to show that dabigatran is superior than warfarin in preventing stroke and minimizing the intracranial bleed. So no doubt about it. And so my question to all of four of you is that do you think that dabigatran induced GI symptom is very frequent? I don't think so. I just wanted to, Shomo, what do you feel?
Sir, in my view, it is almost similar with rivaroxaban. I have prescribed almost all the drugs to many of my patients, be it dabigatran 110 milligram twice a day, be it apixaban 5 milligram twice a day, or rivaroxaban, which is widely available now in the market. So what I think, it is almost similar in my opinion. What I have found, it is almost as similar as that, and it is specifically higher definitely in the females, with aged females. But what I thought, in those females specifically, I have found a GI bleed. It was either a CA carcinoma embedded in any part of the body, or any other bleeding risk definitely is there. And as sir obviously we have mentioned, we have to think twice before prescribing any of the NOACs, that the hemoglobin is the most important thing. And many of our Indian females or males also are having either iron deficiency anemia and maybe anemic definitely. So I think what we have to correct is first that the hemoglobin, and after that and if we correct that hemoglobin, definitely the chances of paroxysmal atrial fibrillation is also reduced, what I think, because the heart failure, atrial fibrillation and all those complications are also reduced with correction of the anemia. And in my view, dabigatran and rivaroxaban has almost similar GI bleed. But what we have taught from the RELY trial, Aristotle, and the Rocket AF trial, if we compare the three trials, there is definitely a meta-analysis that dabigatran has a higher GI bleed. It was proven in the meta-analysis, but apixaban has definitely a reduced bleed, GI bleed, definitely it is proven. But in my view, it is almost similar, sir, and it depends, and it varies from person to person. It varies from the own body reaction of that. Each patient is different, what I.
Absolutely. Great input from the thing. So what we have learned from Shomo is very clearly that it may unmask the undiagnosed GI malignancy. So that's a good thing actually. If you have a GI bleed, don't blame the drug, but understand that you have been able to diagnose a disease which was not been diagnosed earlier.
Yeah.
And
Definitely.
that's most important. Dr. Shobi.
And not only the GI bleeds, sir, the bladder carcinoma, prostate, in those patients mainly bleeds actually.
Absolutely. Dr. Shobi, the next important thing is that do you think that if you stop anticoagulation suddenly, there is any problem? And this patient who have a Chatsworth score of 3 can develop a cerebral event or a peripheral embolism?
So once we have confirmed that the patient needs anticoagulation, then it has to be continued. However, in some situations when complications unfortunately arrive, then we may have to stop at least transiently. Well, there will be chance of complications of either systemic embolization or cerebral embolization. But anyway, we have to balance between these two. I mean, we have to tackle the complication first, and whenever possible, then we have to restart the dose.
Absolutely. Dr. Tanmay, do you think that we should give proton pump inhibitor in all these cases?
Prevent the GI complication or anything? PPI? No, sir. As such, as far as this NOACs are concerned, there may be some GI intolerance or GI complaint, but PPI is not indicated for any of this to prevent GI bleed or.
Absolutely, absolutely. So it's a great insight actually with everything. So do you want to discuss further, or I think we have given a very clear mandate? Yes, Shobit, you wanted to say something.
Yeah, just I want to clarify that dyspepsia and GI bleeding is two different problems. And the problem with dabigatran is that it creates dyspepsia, and almost 1 out of 5 patients develop dyspepsia. But it may be mitigated by taking the drug with food or just after food. But GI bleeding is not higher with dabigatran. Rather, it is higher with rivaroxaban. Dabigatran creates dyspepsia, but it doesn't cause increased GI bleeding, which is caused by rivaroxaban. So it's different. And for PPI, I think if the patient develops symptoms of dyspepsia, then we can add the PPI. Otherwise, routine use of PPI is not recommended.
Absolutely. So, Chinmay, or any other thing?
Yeah, Omkarji, can you take little questions from the audience?
Yeah, there are some questions from the audience.
Yeah.
If the patient is currently on a NOAC and is about to go a PCI, so after the procedure, should he be put on DAPT and anticoagulant? And if yes, for what a duration it should be?
Great. This is a good question. So he's going to volunteer. All 4 of you are master. Some of you volunteer.
Sir, I just want to know what is the indication of PCI here? If it's an acute coronary syndrome, then we have to start.
Acute coronary syndrome.
Yeah, in that case, we have to start with triple antithrombotic therapy. That means clopidogrel, aspirin, and a low dose of either rivaroxaban or dabigatran. Or if you want to choose warfarin, then it's okay with us. No problem with that. However, it's better to use lower dose of dabigatran or lower dose of rivaroxaban along with dual antiplatelet, and in that case, clopidogrel has to be chosen over ticagrelor or prasugrel because of lower bleeding risk. But this triple antithrombotic therapy should be continuous for at least 1 month. At least 1 month. And if there is less bleeding possibility or more thrombotic risk, then we have to continue for 3 months at least. Then after that, we can switch over to dual antithrombotic. That means clopidogrel with 1 anticoagulant for another 12 months. And beyond that, after 12 months, we have to continue only with anticoagulant, no antiplatelet.
Okay, thank you. There is one more question coming up. Currently, if my patient is on prasugrel, and if I want to switch him to ticagrelor, is it possible? If yes, how?
Is it an acute setting or chronic setting?
Acute.
Acute setting, yes. We have to. We can switch over to other drug, and that switching over should preceded by loading of the second dose, and that loading should be done 24 hours after the last dose. That means if we are on prasugrel, then we have to wait for 24 hours and switch over to ticagrelor, and while switching, we have to give the loading dose of ticagrelor. But that should not happen within 24 hours, but beyond 24 hours.
Okay. Sir, one last question I will take.
No, I just wanted to make one comment on this, Dr. Kanjilal, that this is what the way you have to do it. European Society of Cardiology in 2020 has said that the most evidence-based switches between clopidogrel and ticagrelor, not with anything else. I mean, ticagrelor patient can be shifted to clopidogrel, or clopidogrel can be shifted to ticagrelor, evidence-based. And if the other way around, that is from ticagrelor to prasugrel, or the other vice versa, what Dr. Kanjilal said, I agree, but the trials or the evidence is less. Yeah, please.
Last question, sir. Who are the probable patients for ticagrelor 90 and ticagrelor 60?
Tanmoy or Sudev, who wanted to answer?
All SCS patients being managed conservatively, medically, or with PCI are candidates for ticagrelor 90 milligram twice daily for about 1 year. After 1 year, we can shift to 60 milligram twice daily in these patients.
We have
Yes.
data regarding Pegasus TIMI trial that we can use low dose ticagrelor 60 mg after 1 year. And it has been shown to be equally effective without increasing the bleeding risk. But before that, in ACS setting, it is better to continue, if possible, for at least 1 year with a 90 mg twice daily dose. And considering this first question, if the patient was on NOAC, and if you are planning for PCR, for any indications of NOAC atrial fibrillation, then there's one problem regarding that during the procedural access to femoral and radial, there may be the increased risk of bleeding. There are several studies regarding femoral versus radial also, but both were seem to be safe and equally effective. However, initially it was told that you have to stop NOAC 24 hours prior to planned procedure, so that you can assess proper anticoagulation level, coagulation profile, and you can choose your the post-procedural antiplatelet agents, and you can use the heparin during the procedure. But in case of ACS setting, there is no such a point of stopping 24 hours prior to procedure. In that scenario, you have to use other form of anticoagulation, not certainly NOAC. And if it is for the AF, then you have to choose post-procedural access, as Sovigda has clearly said that we have a clear-cut guidelines regarding triple therapy, then followed by dual therapy.
Absolutely. This is very important. And for the access is concerned, radial preferable, but if it is not, then femoral. And there are studies which shows the left femoral has a problem in hemostasis, left femoral, right femoral not. Maybe because we are not habituated in puncturing the left femoral very frequently. So these are all, but the take-home message is that we wanted to conclude this discussion because my speakers, my friends are all tired. I was sitting actually at home since afternoon, but they are doing a lot of work. So I wanted to give them a rest, and thank you, the Alkem team, and thank you very much for the active contribution from Sudev, Somo, Souvik, and my dear friend Tanmoy, and Team Alkem as a general, and you can give some concluding remark, please.
Yes, sir. Thank you so much. We take this opportunity to thank Dr. Shunip Banerjee, sir, for wonderfully conducting this debate and ensuring that all the audience are enriching with clinically relevant messages. I also take this opportunity to thank Dr. Souvik Kanjilal, sir, Dr. Tanmoy Majhi, sir, Dr. Somo Kanti Dotto, sir, and Dr. Sudev Mukherjee, sir, for sharing your relevant, important clinical experiences. And I would also like to thank all the doctors who have joined us for today's panel discussion and debate. And as you know, we at Alkem will definitely continue to serve all the doctors and all the patients by making our product Deviclot, Ticavic, and Tisat available in all your nearby chemists. Thank you so much. We'll continue to do such academic session very frequently. Thank you so much, sir.
Thank you, sir.
Thank you.
Good night, sir. Take care, sir.
Good night. Good night.